3 faculty members may ask questions, and the deans. Okay, let's get started. So for those that don't know, I'm Sarah Velasquez. I am the Communications Core Director. If you're a student, you've probably received emails from me about filling out surveys. You will receive those for the rest of your life. If you are faculty, you've probably received emails from me about opportunities or events, or if you're coordinators, you know who I am. You receive plenty of emails from me. So I also run the social media and the website and work on that kind of stuff. So if you see or hear of any great news about any of our students, please let me know. Even if it's about yourself and faculty, because we like to celebrate all of the accomplishments of anybody that's in K-INBRE. Today for our seminar series, we have Jennifer Schroeder, who's going to talk about, she was a K-INBRE student with at Emporia State University, and she is going to talk about her experiences with K-INBRE, what she did after K-INBRE, and what she does for work now. So I'm going to hand it over to her. You're muted. There you go.
It's been a day. Sarah's heard about it. It's been a day. Apologize now. But anyway, you can all see my screen? Excellent. So like Sarah said, I am Jen Schroeder. After graduating from Emporia State University, went on to get my master's in public health and have then become an infection preventionist. We will go over what that means in a little bit. But you've already kind of shared my background. Went to Emporia State from 2008 to 2012. I was lucky enough to get invited into Dr. Burnett's lab in about 2009, where I kind of found my love for research and then carried it through to my graduate school, where I went and got my master's in public health at the University of Kansas School of Medicine at the Wichita campus, where I focused in epidemiology. My K-INBRE experience was kind of twofold. So originally I got into Dr. Burnett's lab by taking over a project from a student that was graduating, the ever lovely Jessica Johnson. And from there, we started with the first project, which is that top one, the small intestine tissue culture model to investigate first exposure bacteria. And we basically worked on that project, and I say we, because Dr. Burnett did help me a lot. Worked on that project. We presented it at the K-INBRE Annual Symposium, the Kansas Academy of Science, and then the Emporia State Research and Creativity Day. And then that project morphed into the second project that we did, which was looking at first exposure, induction of gene expression, and looking at what immune genes were expressed for our current project. And I presented that at the same places. And then I also went to the NISBRE biennial meeting, which was pretty fun. My K-INBRE experience, though, not only was learning how to conduct a research project, but also looking back now, years later, it has allowed me to gain confidence in not only having a questioning culture, but coming up with ways to, can I answer this question scientifically? Can I apply it to a workplace problem? It also has added to my confidence in like public speaking and just knowing that people are going to ask me questions and I can confidently answer them. And then other thing that it has allowed me to do, which I have learned recently, is take a step back from your project, look at the big picture and troubleshoot. And we used to do this via lab popsicles. I heard this is not a thing. So anybody in Dr. Burnett's lab right now, you need to really kind of embrace the lab popsicle. Looking back, those lab popsicles, I even have those moments at work now where I am stuck, I cannot move forward. I need to step back, walk away, do something else, enjoy a popsicle, and then I've come back and I can look at the picture from a broader perspective and figure out the solution. So that is one thing that I really it's kind of funny now, but I really enjoyed that ability to learn how to do that. And that's one of the things K-INBRE has allowed me to do. Post K-INBRE, I went to get an MPH or Master's in Public Health, focusing in epidemiology. And it was something that, while I was in undergrad, is not something that I really ever considered. I figured I, like a lot of other people, needed to go be a doctor, go to med school, go to vet school, go to PT school, any of those big schools that you're like, when you go to undergrad, you're like, I need to go be a doctor. Well, another professor at Emporia State University recommended, hey, Jen, you enjoy figuring things out. You have a questioning culture. What if you go get your master's in public health? And I was like, what? But after looking into it and looking at that, a master's in public health is a way to also do what I did in the research lab, but also look at it from a population health or like an overall what's going on. I can make it more relatable to what's happening now. So previously I was working at literally looking at gene expression in mice models. I was now able to look at questions that were affecting populations around me. And so that was something that when I originally started with K-INBRE, it was not something that I thought was even on the table. But now looking back, it's something that K-INBRE was a stepping stone to go and have this questioning culture and figuring out, what do I want to do that will fit me with my lifestyle and what I enjoy. So while I was getting my MPH, I was an intern with the Kansas Department of Health and Environment in Sedgwick County, and my capstone was actually looking at neonatal hepatitis B vaccination rates, because during this time they were looking at it from like 2005, 2012, and trying to figure out who can we target with education to get new mothers to vaccinate their children, because rates were just plummeting. And so with this, I was able to use that background of, okay, I know how to ask a question, and then how do I build a project from this? And so for about 9 months, I worked on this project with them, and it allowed them to kind of look at what demographics are vaccinating their children and what are not, so they can target those areas in the community that were not vaccinating their children. So that was something that was pretty interesting, that I thought was pretty fun to kind of build upon. A lot of other people in my graduate program, I remember them going, how is this easy to you? And I was like, it's my training from undergrad. You asked a question, and then you started brainstorming, how do I figure out the answer? And you make it a research project. So it was something that we got to do, which I thought was fun. And other people were like, man, I wish I would have got into research more. So it was something that really did help me in graduate school. Life after graduate school, I moved to Houston and accepted a job as an infection preventionist. I am now in New Orleans, and I have been for the last 5 years. I'm still an infection preventionist, but I have achieved certification as an infection preventionist. I've worked at various hospitals that allowed me to get experience not only with adult populations, but as well as pediatric populations. And these are kind of some buzzwords in the infection prevention field, and we will go over what that means in a minute. But I have experience with level 1 trauma centers, labor and delivery, neonatal intensive care units, bone marrow transplant units, burn units, some other things that you don't really hear about in hospitals, but how do they clean things? So I have experience in sterilization practices and high-level disinfection as well. So a lot of you are probably like, what is an infection preventionist? I didn't even know this was a thing. I didn't either, full honesty. But most hospitals have an infection preventionist or an infection prevention department. It can typically consist of a nurse. However, it's shifting towards people with advanced degrees, typically master's level or above, that can do kind of high-level critical thinking. And they are typically embedded in the patient safety and quality department. So also another thing that I did not know about when I first entered this field, there's this whole background in a hospital and in healthcare that not only is looking at patient outcomes, things that you're required to report by the state, but they're just trying to figure out, how do I make my hospital have better patient outcomes? So I am embedded in the patient safety and quality department. It can also be called performance improvement. Typically, it's going to be performance improvement or patient safety and quality. They do the same thing. So I am at my current job, I'm leading their infection prevention department. And some of my day-to-day activities are, I look at their surveillance. I want to figure out, do they have any hospital-acquired infections? Which is really important because in 2015, CMS, Centers for Medicare Services and Medicaid, have passed a law where they are no longer reimbursing you if the hospital caused the patient to have an infection. So you're no longer going to get any money. And now that healthcare is a business, they want that money to stay open. So they quickly figured out, we need to figure out a way to create processes and practices that we are not going to cause harm to a patient. So one of my roles is to kind of monitor what kind of hospital-associated infections we have going on. I also am in charge of employee education when it revolves around infection control practices, which could be the importance of washing your hands, how to put on personal protective equipment. Well, we'll go and walk around like, what can you do in a construction site? How do we keep our patients safe? So that's some of the things that we do education-wise. We also will work on hospital-associated infection reduction projects. So these are my favorite because they get to basically be an entire research project based on what we were having an issue with. And we'll kind of see an example of one of those later on. We also are in charge of regulatory readiness, which hospitals have to undergo an accreditation. So they're accredited by either a accrediting body called the Joint Commission or the DMV. In order to get CMS funding, you have to have a valid accreditation from one of those places. On top of accreditation from those places, the state gets to control you basically. So you also have to follow all state and other regulatory requirements that they put out. So on top of that, I am also in charge of making sure the hospital from an infection control standpoint meets all of those. And then finally, policy development, everyone's favorite. You get to write some policies and make sure that they keep you in line. So that in a nutshell is infection prevention. Some of the kind of cool projects you get to do. So this is a hospital-acquired infection project. So one of the big things that we look at are things that we don't get reimbursed from CMS. So we look at if you have a patient with a central line and they develop a bloodstream infection, CMS is not reimbursing you for their entire visit. So if they're there for 6 months, all that payment is gone. So you want to try and prevent that. So here on this chart is looking at the number of infections that we've had as well as our standardized infection ratio. So this is how we compare to other hospitals that are of the similar size that we are. So you can see as in Q1 of 2019, we had a huge problem. We had 14 infections in one quarter. So if you think about it, putting a face to that, that's 14 patients that we caused to have harm. They had to stay longer. They could have died. They had to get exposed to more antibiotics. They could have had other medical complications, all because we caused this event to them. So since that time, we have actively looked at how do we reduce these by formulating many research projects by doing this. And you can see that as over time, we have gotten drastically better. And we're going to continue to do these kind of projects to continue to better our outcomes for our patients as well as just not cause harm. So this is one example of an infection prevention project. Another example that everyone got to live through, COVID-19. So I still remember this vividly to the day. We were very active in that to the point where March 9th happened here in the city of New Orleans, and we had our first case, and the hospital mobilized incident command, knowing that we need to start preparing for a mass influx of patients. We need to start preparing for how do we handle these patients. We need to start preparing for what happens if we don't have any supplies. all of those things happened. It was really fun. One part of this incident command was they quickly realized they needed help from infectious disease doctors and infection control. So that really kind of started how I now work together as a part of patient safety and quality with the infectious disease team. So we're not synonymous. Infectious disease doctors will typically just take care of the patient, whereas infection control looks at the background. Yes, I want the patient to be taken care of, but is staff set up to be appropriately taking care of the patient? Are we set up on the background to get everything done? So we got brought in on March 11th, and we were basically in a windowless room with lots of whiteboards, and we would basically be processing out all of the questions that were coming to us, like how do we handle our PPE supply runs out at the end of today and we don't get a shipment for 5 days. What are we going to do? So those were a lot of things that we were working on. And if any of you joined in earlier, you got to hear me say there were times where I had a little tent card when I went home personally, and it said, do not wake me up unless these 3 numbers called us. Partly because we were on call 24/7 responding to some of the crazy things. I was always paired with a provider, and one of the providers that I always paired with, we always got the weirdest calls when we were together, on call together. And so we would call it the witching hour. At 11 o'clock, we would check in. At 2 o'clock, one of us would got called, probably both of us. So we'd reach out to each other and say, okay, this is what I'm hearing. Then we decide, do we need to go back to the hospital or can we handle the problem from home? So that happened probably until the middle of April. I don't think I came back to my office until the middle of April, and I had to evacuate. Basically, there was still coffee in my coffee cup from a month ago. It was basically like, pick up your stuff, pack it up, let's go. So we came back to our office and started doing our normal day-to-day stuff on top of our COVID work. And what that looks like is we are still working on processes with how do we continue to roll out PPE usage. So we went from having absolutely no PPE to still having some shortages even today. How do we handle patients like with flow? Where do they go? Where can they move around the hospital? I work at a pediatric hospital, so one of the options that the adult hospital in the healthcare system that I work at was, we're just not going to have any visitors. Well, I don't know if you've ever been around a mom or a parent of a sick child, and you're going to say, you cannot stay with your child while they're in the hospital. So we had to quickly figure out what would that look like in a pediatric perspective. We also, in this time, it happened to fall on, we're now in our regulatory readiness. So we have that accreditation survey coming up. So we're working on that. So it's just been a big of major players in the COVID-19 response. And then how do we bridge that into our everyday jobs? So one thing that I have kind of learned from this experience is really kind of acknowledging and enjoying the fact that I can step back, look at a problem, take a minute, and then figure out how do we move forward with this problem versus getting bogged down in kind of like the stress of it all. And some of that I do thank from my experiences with K-INBRE, although I can't say that in Dr. Burnett's lab I ever worked with a pandemic, but there were times where we were under crunch time and there were stressful situations and we needed to figure out how to move forward, and we were just blocked. And so like drawing on some of those experiences during this time was very nice to have those skills, but also it was just like a sigh of relief. I didn't have to relearn that. So that is 2 of the kind of big things that I do as an infection preventionist. I'm now going to open it up to questions that anybody could potentially have about all that.
That was very interesting, Jennifer. Congratulations for your interesting job and surviving quite an eventful year. And I'm jealous of the New Orleans thing because I'm from close to down there and I miss eating the food down there. So when you're going through and back last spring, for example, did you get pushback or resistance from people who thought you were trying to tell them what to do and how to do things? And was that difficult for you?
Absolutely. So me being at a pediatric facility, we weren't hit as hard as some of the adults were in the city. I think if anybody remembers that, we were a hotspot at one time. So we were tasked with trying to figure out, how do we conserve our PPE, or our personal protective equipment? So before the pandemic, we used to just say, you use one gown, one set of gloves, one mask, throw it away. Well, now I'm telling people, you gotta wipe it off, take it off nicely so you don't ruin it. You have to use the same mask. So getting people to understand that we are in the Wild West right now, and I'm not doing this out of malice. It was, we are doing the best we can with the data that we have. And this was also when everything was changing every 10 minutes. We used to look at our clock when someone says, is this the current recommendation? And we'd look at our watches and be like, well, it could have changed because we told this to you 10 minutes ago, so it probably will change in the next 10 minutes. But as of right now, this is the best we have. We did end up, one of the biggest things was the conservation methods that we ended up using for our health system that me and my colleagues wrote was adopted by the state of Louisiana. So that was one thing that was really kind of nice. And then months later, as the CDC got more information, they actually did validate the things that we were doing, but it was kind of rough at certain points because people had to trust you. And I don't know if I hadn't been at this facility prior, if I would have been able to come in and they would have had my trust, because people were physically and emotionally just drained and scared and worried, and everything was changing. And we just kind of had to have this steady, like, we are all here with you. We are looking out for your best interests, but this is what we have to do at this time. Sarah was hearing me talk about it. We're doing a similar problem that we were dealing with this morning, but nowhere near on the scale of the COVID-19 PPE response.
I can imagine after this experience and what you've done, that your skills would be in very high demand, and your potential for someone to come in and say, hey, we could use you over here or whatever, to hire you away. That sounds like really valuable experience.
Yes, I would definitely agree. The field of public health now has only been exploding due to this pandemic. So there are a lot of people that I just hope that they can also say, well, I really like research and I like doing all this, but maybe I don't have to be a doctor. Maybe I have a different avenue to kind of continue doing these types of things that I enjoy, but also in a field that would fit me or fit my needs.
At some point, we have to hear about the snake.
We have some students on here. Do any of the students have questions?
I did have a question. So Jennifer, you are doing exactly what I want to do. I just got accepted to KU Public Health here in Wichita. I'm really excited, like just got it yesterday.
Ooh.
And so what you do is exactly what I want to do. And I was wondering, what did you do when you got out of public health that you knew where to look to go to get to where you are?
So I'm going to be completely honest. I, like most people who are finishing their degree, have this panic. My degree is ending and I need a job. But what I did was, in public health school, they basically will kind of say, hey, you can go be a state epidemiologist, which I looked into that. But I started broadening my search engines and looking at public health. I was kind of a black sheep in the School of Public Health at KU because they primarily focus on chronic diseases, and I was always interested in more of the infectious diseases. I remember my favorite classes being like pathogenic micro and things like that. So I started using those in my search engines, and I really just was like, I'm going to continue to look for just various different types of jobs until I stumbled upon an entry-level infection preventionist through a consulting company. And I had no idea what it was, but you know what? I was excited. I felt like my background prepared me enough that I could do it. I was also a quick learner, and it turned into something that I really actually enjoyed, and it fit really well. And so it was just one of those things that I was applying to not just state epidemiology positions, but I was applying to like healthcare positions, and I wasn't afraid to get a no. I got a ton of, you're not what I'm looking for. And I was like, okay, here we go. I think at one point I was living at my parents' house at this point, which I told everyone in grad school that I was living with this elderly couple, and I rented out a room from them. So they were getting mail from all my letters of rejection, and I was like, it's all right, just toss it in the pile. But I just never gave up, and I always just tried to get creative with my search engines, and I wasn't afraid to travel. So that was another thing. Certain states still require their infection preventionists to have a nursing degree. However, as we move forward and we are continuing with nursing shortages, they are now seeing that it is valuable to have someone with a data background, especially because within the last 5 years, a lot of infection prevention is data driven versus it used to just be you went out and you taught people how to wash your hands and walked around with your clipboard and you were done. Now it's really like, how do I use data to drive outcomes? So a lot of them now will have a department that has both nursing and non-nursing, so you can bounce ideas off each other, and it just makes it for a better department.
All right, thank you.
You're welcome.
So what were you doing before you were at this hospital?
So I, as of Monday, actually got hired on by this hospital. I was a consultant. So I was a consultant for 6 years, and they were my entry into this field. And they allowed me to have all the experiences that I had, which was part of the consulting is you move a lot. So I probably worked at 5 or 6 hospitals in Texas, and then I moved over to New Orleans with this consulting company and got to experience not only community health centers, pediatric hospitals, small critical access hospitals, but major level 1 trauma centers. And so with that, I was able to kind of find what I really wanted. And so I kind of moved over and wanted to stay. I was over kind of traveling a lot, and I wanted to be settled and stable. So I was like, this is where I want to go. Upward projection for me looks to be like a lot of infection preventionists can elevate up into being the leaders of their departments, their managers, the directors. They can also shift over to being directors of patient safety and quality. So there's a lot of things that they can do. There's also a lot of non-traditional things. You can work for medical supply companies. So a lot of them nowadays are hiring infection preventionists so they can understand, like, I have this medical device, and infection preventionist is going to help me figure out, like, look through, how do I clean it? How do I educate that to people? Because that's now becoming a major thing. So you also have the hospital-based infection preventionists. They are now looking at infection prevention in nursing homes, group home types of settings, rehab hospitals, but I've seen a large increase in the medical device sales as well.
Are you the only one in the only infection what is it? What is your
Preventionist?
Yes, preventionist.
So currently now I'm the only one. I have worked on teams as large as 5, and I have remotely managed teams as large as 9. So I would say remotely managing teams is a little bit more challenging than in person, but it's something that you can easily do if you set yourself up to be like, okay, I need to figure out, it's another puzzle, just like research. How do I effectively communicate to these people that I can't be with every day?
So with the your consulting gig, there was a company that hires people like you to work around the country for clients that need them, right? And
Exactly.
so that's, I guess that's working for this company. Then you were able to get your health insurance from them and all that, right? So when you first said that, I was thinking like independent contractor, but that would be different. So that's good that there's an opportunity to work as a consultant for a company. It sounds like an exciting job for someone to do for a while.
Yeah, it wasn't a independent contractor type situation. You were employed by this consulting company. They would train you. They also would move you around, which for me, at that time in my life, I was young, I was single. I was like, let's pack up and go. I had one dog at the time. He was very good in the car. So we moved all about.
With those jobs that you did with the consulting company, like what was the shortest time frame and like what was the longest? Because I know you've been with your current position for a while, but you started out with the consulting company. So what kind of ranges did you have?
So I was at the consulting company for 6.5 years. My first job was 3 weeks long, and I trained with a group of people. And then I went to managing a program at a hospital that had 2 locations. And I did that for about 6 months. And I remember my first day, their accreditation survey walked in, and I was just like, oh, okay, here we go. Gotta put my confident face on, but behind closed doors, I was really anxious and a little nervous. But then I was at another facility for about 6 months. Then I got to the point where I started doing year-long contracts at certain facilities. So I'd be at a place for about a year, and then it was, okay, we're ready to move around again. So.
Anybody else have any other questions for Jen?
I had another question I just thought of. Do you see yourself trying to get to like CDC level, or do you like where you're at right now?
Initially, I thought the CDC was a goal, but now I really enjoy where I'm at. I'm actually thinking about going back to school and doing that full time, or doing that part time while working and getting a doctorate in public health, looking more at patient safety and quality. So the CDC is probably still on the table, but I wouldn't say it's no longer like, if I wasn't at the CDC, I would be a failure. I work for a small health system that is now, when I first started, it was 5 hospitals, and now it's 6 hospitals. So as they grow, they're going to need system level support. So I can see myself growing up to being like a vice president of either patient safety and quality or infection control for this health system, I could also do that at other health systems, but I really enjoy the culture of where I am now. As John was saying, the food, can't go wrong with the food. I don't know if the CDC has New Orleans food.
All right, thank you.
I also have a question real quick. Hi, I'm also an undergraduate student interested in public health. And I was wondering, since you've been to so many different types of hospitals, were some of the challenges that you had to deal with, like the infections, were those kind of the same across the board, or did they differ with the different types of hospitals?
So the concepts behind the infections are kind of all the same. What I've learned now is when I find an infection, what I like to do, and we have a team that it's a little bit easier than a solo person, but what I like to do is I like to go and talk to the nursing staff and the doctors, and let's have a round table and be like, okay, here are the nuts and bolts of what's happened. It happened. What can we do to prevent it from happening in the future? And so some of those themes are pretty repetitive. It's how well are we at taking cultures, like taking blood cultures or obtaining samples? Did we really need this? Did we do everything that we should have done, like cleaning and disinfecting and just being careful? So it's those types of things that are pretty common. The difference is right now I work in like a pediatric facility, and the culture at this hospital, they take it personal. If someone gets sick on the unit and it's discovered that they have a hospital-acquired infection, they're like, we caused harm to this person, and they feel terrible. Not every hospital is like that. Some people are just like, well, I don't agree, this is fine, the patient's fine, but it just depends on where you work. So I've worked with a lot of different personalities and challenges, and I do work hand in hand with providers. And so a lot of my job is just almost networking with them to realize that I am a resource versus the stereotypical infection preventionist, which is the sheriff's badge with your clipboard and your pen and you saying, excuse me, you're not doing this right. It's how can I help you be successful? Because when you're successful, I'm successful.
That makes sense. Thank you.
So you're in the pediatric unit, correct? That's what you're saying.
Yep.
And so there are others like you who are in other units of the hospital.
So my hospital is all pediatrics. We'll treat patients up to 23, but there are others like me in other hospitals. So for example, the health system that I work for has 6 hospitals. One hospital is a level 1 trauma center. They will take all of the major trauma throughout the region. They have a helicopter, they fly them in, they have a burn unit, they have all sorts. It's a fun time. It's in the middle of downtown, so they also get that kind of population, just that quick in and out population. Then there's 2 other hospitals that are more community based. They're kind of tucked back into neighborhoods. They predominantly have the nursing homes and the senior care. They both are where you deliver babies at. Then we have one that's, 3 of them now. Sorry, there's 3 of them that are very similar like that. They're tucked into neighborhoods. They're community-based hospitals. Then we have a hospital that is, I like to consider out in the middle of nowhere, but it was hit hard during Katrina, and this hospital is still rebuilding, where they're literally, it feels like a critical access hospital. That's the only place that these people have. So what the patient population they see is very different than what everyone else would see. They're mainly like, I'm using my emergency department as a doctor's office, or I'm not feeling well. They'll also get emergencies, but they're just a smaller scale to that.
So are your skills pretty transferable or generalizable across all those different types of facilities, you think? Or are you pretty much a specialist for where you are?
No, they're pretty transferable. So as I've trained people and they move to other facilities, so I just got finished up training someone who moved to what we call the adult world. So I'm in the pediatric world. My last parting words to them was, remember, the concepts are the same. What we're trying to do is the same regardless of what age you are. How you go about it and how you do it might be a little bit different. So likewise for the COVID-19 pandemic, in the adult population, they just said, you can't have visitors. Fine. I was not about to stand between a very scared mom and a sick child and say, hi, you can't come in, leave your child with us. So we had to figure out what works with the whole overall goal is how do I keep the population safe, my staff safe, and the patient safe.
So Jen, if all of these hospitals have somebody like you working there, why do they hire consultants? Like, is that for a special project, or what's the business model for this consulting firm?
So not every hospital actually has this. They'll either have someone that it used to be, this is where you go to retire. So you have someone that's at retirement age, and then you have the department that's vacant because there is not a huge, I didn't get trained for this in college. I did a lot of on-the-job training. So a lot of people will hire consultants to just get their program up and moving until they can figure out how they can do it internally. Some of them will hire you because they had a bad accreditation and they might be on track to, I have to either fix it or I don't get to open my doors anymore. So the consulting company could do two things. It could be a special project, or it could just be like the hospital doesn't have the means to staff their own department. It used to be one person, but now they're understanding that you need more than one person depending on how large your bed size is. So 5 years ago when I arrived in New Orleans, the level 1 trauma center, which is a 500 bed facility, had 2 people doing this job, which is pretty insane and a little impossible. And now they have 5. So it'd be like that. They need help just filling these spots until I can get the right person, because there's no magic tree farm that says, here are infection preventionists ready. You have to, as a hospital, you have to have a decent training model to get these people trained. They're not going to come to you. They could come to you, but it's very unlikely they're going to come to you trained. So you have to really kind of recruit someone and hire someone with the skills you desire, and then you teach them how to do the job. So that's one of the things that I am not afraid of hiring someone who's fresh out of graduate school if they have the traits that I desire. So if they're a quick learner, they enjoy doing things. I actually prefer people who are opposite of me, because then we can like work better together. They'll think of something that I will not think about. But if I only have to train you how to be an IP and you already have these other skills, that to me is a much better applicant.
So do you think that your hospital now, that you're pretty well accepted there, that people are pretty okay with you and what, you know what I mean? Like kind of what John was talking about being people maybe being a little bit hostile towards you because of what you do.
Yes, I would say that we're now kind of at the point where they, instead of just saying, oh, we have to call Jen, they're like, we need to call Jen. We need to ask her opinion. The infectious disease doctor that I worked really close with over the last year, we kind of have this joke that no one really knew outside of the patient safety and quality world and maybe a couple other departments in the hospital who we were and what we did. And then we kind of walked into the COVID team and we're like, hi, we're going to take over. Can we have this office? Because it has all the whiteboards. And that really, the hospital really embraced that. I know I've had a lot of friends that I've networked with across the country that COVID-19 really either elevated them or had people like, the response was mostly they were like, I've never felt more empowered in my job. However, there are some hospitals that did not embrace them. So it is a job for someone that you have to understand that tensions are high. You got to have thick skin. I have been screamed at before by a physician because I challenged him and he didn't agree with it. And it's just one of those things that you have to know too, that your intentions are not to embarrass anybody or to make anybody feel bad. Your intentions are there to have a better outcome for the patient. And it's kind of also how you explain it and how you educate. So it's been a long time coming. You remember that graph that I showed that had the purple bars with the light blue lines? There was a problem in one of the departments at the hospital that I worked at where they just had all of these infections and no one really owned it. No one really thought that there was a problem. And finally, we just had a conversation that was like, what is going on? And when you showed them the numbers of where they compared to other departments like them across the nation and how they were off the chart worse than everyone, is when they really realized infection control is not picking on me. Jen's not out to get me. Something is really wrong. The data does not lie. So a lot of the times I have to try and also, when I'm going to give a hard decision, I have to try and remember to take the emotions out of it and just know this is what's the recommendations say. This is what our data shows. I understand that you may not want to hear it, but this number doesn't lie. So we have to fix something.
Does anybody else have any more questions for Jen before we let her go? I think she has a pretty busy day today.
Do we need to say the snake story?
Yes, we want to hear the snake story.
Yeah.
Do you want to tell it, Dr. Burnett, or you want me to?
I can tell my side of it. You can tell your side of it. So I'm sitting in the conference room in our biology office, and just like a lot of the smaller campuses, you know, biology is all of biology. It's not just laboratory biology. So we have people that study snakes, and they keep snakes in their lab and look at their behavior. And occasionally those snakes escape. And so we were getting ready for a lab meeting, and we were downstairs in the lab and getting ready. And I went ahead and came up here, and I got a little bit annoyed because somebody had stacked all these boxes on this table. And so I needed to clear those boxes off to make room for my students that were coming up. And as I moved the first box, in between the two boxes was a snake. Totally unexpected. It came out of nowhere. And I had a box in my hand, and I was staring face to face at a snake. And I may have yelled or screamed a little bit. And I think Jen will tell you she could hear me screaming downstairs in the basement, clear across the building.
Yeah, a little geographical layout. So if you're in one corner, we're in the opposite corner on the lower level in the lab. And it was during the summer, so really no one was there. And it was just our group. I think there was like 5 of us, maybe 5 or 6 of us. And everyone goes, what is that? And was Dr. Thomas there?
I think so.
I think he came and helped you out, but we all came upstairs laughing. We were not about to help you out. We were just like, you got it. It's fine.
I'm not really afraid of snakes. It really startled me. And I'm still kind of embarrassed about how loud and how high pitched my scream was when I saw that thing. So thanks for bringing that memory up, Jen. That's really nice of you.
You're welcome. It's got to live on.
That's information that we might take advantage of sometime.
He's conquered the fear, though. I remember there was also another story where he had to get rid of a snake you were camping or something, and you had to carry one off, and you're like, I can't squeal and scream. I have to carry the snake off. So he did combat the fear.
I got
surprised.
The person who has all the snakes gave me a little card after I saved that, because the other campers wanted to kill it, and I wouldn't let them kill it. I wanted to move it, and I told that story, and then he gave me a card that says "Herp Hero." It's still downstairs on my office door. That's a long time ago.
That's amazing. Well, Jen, we appreciate you taking time out of your busy day to come and speak to us. And like all of our presentations, this one was recorded, and we will make it available to all of your students that couldn't make it today. And thank you for that presentation. It was very interesting, and we really appreciate it.
Anytime. Thanks to you guys. If you guys have any students with any questions, or if they think that they want to get in this field, give them my email or my contact information, and I can help try and figure out where the best avenue for them to get their foot in. So we're always looking to get more public health students or graduate level students into the field of infection prevention.
Awesome. Thank you.
Thanks, guys.
Thanks, Jen. Thanks, Sarah.
Thank you. Bye-bye.